Hello, and welcome to LAIVF Clinic's podcast series, Understanding Your Fertility, a podcast series specially curated to answer all your questions about fertility with fertility specialist Dr. Bayrak, and I am your host, Ara Behagan. Today's episode is the second part of a two-part series. Last week, we discussed a fertility treatment called natural IVF. And this week, we want to talk about Mini IVF, or sometimes referred to as Minimal Stem IVF. If you are considering IVF treatments at all, both of these episodes would be a great resource in the different types of approaches to IVF that are out there. And we discuss which type of IVF treatments are best for different types of cases. For any questions that we can address on the episode, future episodes, or topic suggestions, please email us at info@laivfclinic.com. Thank you and hope you enjoy this episode. Hello, Dr. Bayrak. Thank you for joining me today. So I want to talk about a topic that we've been getting a lot of questions about lately. Many patients have been asking about a type of IVF called Mini IVF, which I've also heard called micro IVF or minimal stem IVF. I want you to help me and our listeners understand what Mini IVF is exactly and what the difference is between that and conventional IVF. So I was hoping you could start us off by reminding us what conventional IVF is and then how Mini IVF differs from that.
Hello, first of all. I'll be happy to do that. Yes, so Mini IVF is a popular topic, and it's something that has been around for some time. Mini IVF is really the mini version of minimal stem IVF in a sense that the stimulation of the ovaries is less compared to conventional IVF. So in order to do IVF or in vitro fertilization, we stimulate the ovaries with hormone shots. So we get more than one egg. And depending on reproductive age, protocol, many other variables, but eventually, depending on how many eggs somebody might have, we stimulate the ovaries so we can mature multiple eggs. And when we mature multiple eggs, we aspirate them. Then we have multiple embryos in the laboratory.
And what do you mean by aspirate? Sorry, I just want to step back. So
aspirate means that we take them out from the ovaries.
Gotcha.
So we retrieve them from the ovaries, and so that we can do IVF on those eggs in the laboratory. So if we have a lot of eggs in the laboratory in a petri dish, then we can create multiple embryos. We can create multiple embryos, then we can have multiple embryos that can reach the final stage. Then we can pick and choose the best ones and then inject them into the uterus, possibly test them genetically. That's a test called PGT, pre-implantation genetic diagnosis or testing. Also, we can freeze some for the future in somebody who wants to have more than one child or just starting out the family and they already have infertility. So when you do conventional IVF, it's more of like a numbers game where when you have more eggs, you have more embryos, more to choose from, and typically higher chances because when you grow these embryos, they're not always all normal. So if you got, let's say, 10 eggs, by the time you mature them, fertilize them, aspirate them, grow them, maybe test them and freeze them and transfer them, you may be down to maybe 2 to 3 out of 10 eggs. So there's a dramatic loss, which is probably why the ovaries are giving us a lot of eggs each month. Otherwise, they would just give us one, which would be the one and totally normal, right? So that's probably why. So that's conventional IVF, where you're stimulating the ovaries and you're getting a lot of eggs, right? So the difference between that, which is conventional IVF, and minimal stem IVF or mini IVF, some people call it micro IVF. People have used easy IVF. Like there's all kinds of versions depending on, who uses and what kind of they're trying to kind of relay in terms of what kind of IVF it is to the patients. So at the end of the day, minimal stim means less stimulation. So what does that mean? Well, less stimulation means less eggs. So let's say somebody comes in with 10 eggs, right? And we put her on a protocol of maybe starting, let's say arbitrarily, 400 units of FSH hormone per day. And out of that, out of those 10 follicles or eggs in ultrasound, maybe we'll get like 8 of them, maybe 8, 9, maybe all 10 if we're lucky. So then we would maximize the number of eggs that we get, right? So instead of 400 units, if we use only 200 units, right? So that's lower those, right? Maybe we'll get like 6 eggs, right?
Interesting.
Yeah, so if you use 100 units, maybe we'll get 2 to 3, right? So the response from the ovaries and the number of eggs that you mature are dose dependent. Dose dependent of the medications that we use. So in majority of the cases, the tendency is not to understimulate, right? So if a patient has the potential to grow 15 eggs, right? I mean, you want to get 15 eggs and just get that over with, right? So, and for that, you have to use a certain dose so that you're not understimulating, right? So when you do minimal stim IVF, you're stimulating the ovaries less. Now, if somebody has a lot of eggs or a decent number of eggs or maybe a little bit lower than ideal, that doesn't necessarily mean that you have to do minimal IVF or minimal stim IVF, because you're going to have suboptimal number of eggs or less eggs, right? So instead of getting 15 eggs, if you get only 3, you got 3 chances. If I get 15 eggs, I got 15 chances. 15 chances are better than 3 chances, right? Yeah, simple math, right? So, but minimal stim IVF really doesn't apply to those cases where minimal IVF is really suitable for somebody who only develops maybe 3 to 4 eggs. Not a lot, but more than 1. So then in that case, when we put somebody on a high-dose protocol and do conventional IVF, well, if they only have 4 eggs on ultrasound, you're going to get 4 eggs. That's it, right? So if I put her on 600 units, I may get 4 eggs. If I put her on 400 units, I may get 4 eggs. If I put her on 200 units, I may still get 4 eggs, right? And I can augment that treatment by giving some pills like clomiphene or Femara. These are all medications that we use to stimulate and augment this minimal stimulation approach, which then becomes a little more patient-friendly because they're not injecting high-dose medication. So there's that potentially less side effects from these drugs. There's also less side effect to the wallet or the bank account because it's a little cheaper, right? If you're using less meds, that's going to be cheaper. So that's another advantage. So that's really what minimal IVF is most suitable for an individual who doesn't have a lot of eggs, but also she has more than just 1 egg per month that she can mature. Because recently we did another podcast, Arba, obviously, about natural cycle IVF, right? So natural cycle IVF, you only get 1 egg. It's natural, right? So, and that's really most suitable for somebody who's really towards the end of the reproductive years or has very, very low egg reserve, in the sense that no matter what we do, minimal, conventional, traditional, micro, easy, like whatever IVF we do, we only get 1 or 2 eggs. So in that case, doing natural IVF, natural cycle, or no stim, right? We called it no stim, absence of stim IVF, because natural IVF doesn't make sense. There's nothing natural about IVF, right? So, but it sounds good.
Right.
So in any event, so if you compare a patient who has only 1 egg per month versus somebody who can develop 3 to 4 eggs, well, person who's developing only 1 egg, no matter what, stimulating or not, should really do natural IVF if that's what that person wants to do or is more suitable to do. Whereas minimal IVF really refers to keeping a dose low but still stimulating in order to get more than 1 egg. Because if you get 1 egg, you got 1 shot. If you get 4 eggs, well, okay, if 1 is not good, maybe one of the other three will be good, right? So then you have a chance of still finding a good egg so that we can fertilize and create embryos. So minimal stim IVF is really most suitable for those patients who can not grow excessive number of eggs or good response with traditional IVF, but they can still grow a few, where natural IVF would be an inferior or lower type of a treatment for them. So that's really the difference between these different kind of treatment modalities and stimulation protocols.
Okay, so I have a silly question. So let's backtrack a bit and look at, so when a patient comes in to get a consultation and you do an ultrasound, you look at the amount of follicles she has, you'll be able to tell or estimate how many eggs she's going to get out of that amount of follicles that you see in the ultrasound. So,
that's absolutely correct.
Okay, yeah. So let me see if I'm understanding you correctly, and that is, you, according to the amount of follicles you see, you match that amount of stimulation towards the amount of follicles that you see.
Right, that's absolutely correct. So we somewhat, quote unquote, design a protocol for the patient, and that would be only right for that patient. Now, there are also many other variables, obviously. So if somebody wants to do embryo testing, then we're not going to be shy of stimulating those ovaries, because I need to get a certain number of eggs, embryos, test them, so I can get at least some good normal ones, right? Somebody may say, well, I just want one child, or I already have two. I just want one more, and I'm just having difficulty. And then we look at the case, and most of the things are working, really. Maybe it's timing or reproductive age and its impact on quality. So in that case, I mean, I don't need 25 eggs just to create one baby. So in that case, I'm not going to use a full high-dose course of gonadotropins or injectable drugs, because I don't really need to create excessive number of eggs. So every case, every indication will then determine the type of protocol that we choose. We also have patients who are very sensitive to not having excessive number of embryos frozen. Some patients request that because they don't want to just simply discard these embryos. They may have a moral, a religious, personal connection. They may view things in a way that they may not want to discard these embryos, and that's understandable. So in those cases, we also are very careful with stimulation, so that we stimulate the ovaries enough so that we can get some, but not excessive number of embryos. So there's a lot of consideration when we design these protocols, and it's just not like, okay, you have 15 eggs, it's full-blown IVF. You have one, it's natural. So there's certainly a lot of overlap in that decision-making and really what the patient's needs are. So it has to be tailored towards that.
That's helpful to know, because it also makes me think that we can't just kind of diagnose ourselves and really decide on our own based on what kind of IVF treatment we want to have as far as patients. Like, we can't just go in. We really have to work with you or the fertility specialist that they're with to see what is really most suitable for them. This is really helpful to know, though, about the options that are out there. And as a patient, I would want to know, like, how do I fit in that? You know, where do I fall in terms of which options do I have? So also, I wanted to know if are there any risks to not stimulating enough or doing a low dose of medications? Are there any risks to that?
Yeah. So there's no risk in terms of like a medication risk or a procedure risk, because those are the same. I would probably reword it as a disadvantage rather than a risk. So I think disadvantage would be to understimulate the ovaries and not reach the capacity of that IVF cycle. depending on where you live, what kind of insurance you have, IVF is an expensive procedure if you're paying out of pocket. So if you're paying everything out of pocket, you want to get the most out of that cycle. You don't want to do 2, 3, 4 IVF cycles that are natural or minimal stim, whereas you can just do one cycle and get all the eggs and kind of get that over with, right? So, but the question here is, do you have the capacity or do you have enough eggs to accomplish that? And that's really the key. So if somebody has the potential to grow a lot of eggs, then the disadvantage of doing minimal IVF would be, once again, not to reach that full capacity of that treatment. It's in a way, you're giving chemotherapy to somebody and you're really concerned about the side effects, so you give half the dose. And then you say, okay, let's give another half dose next month. Well, that may be suboptimal treatment of cancer, right? Because you're really not maximizing the dose or the treatment. So that's kind of the way to look at minimal stim IVF in somebody who wants to develop a lot of eggs, embryos, who may want to have more than one child, and who may need multiple embryos, because sometimes when we put an embryo, it's not guaranteed that that embryo is going to attach. And if I have 1 or 2 more, that's really reassurance. If you have additional embryos, you can freeze them. Then you can simply just do a frozen embryo transfer, which is significantly cheaper than doing a full IVF cycle. Once again, if you're paying out of pocket. Also, if you have a lot of eggs, embryos, you may be decreasing the number of procedures that you do on the patient, right? Because each time, if you're taking eggs out, a few eggs, or you're doing natural cycle in somebody who actually can develop 3 to 4 eggs in that cycle, well, you can get 4 eggs in 1 month, or you can get 1 egg over 4 months, right? So the difference there is the 4 eggs that you get are no worse than the single eggs that you get over 4 months, right? But if you get 4 eggs in 1 month, well, that's just 1 procedure. Whereas if you do 4 procedures over 4 months, that's 4 procedures, 4 risks, right? Also, over 4 months, you have a certain impact on infertility, where the egg reserve goes down over time. That might not be dramatic, that it'll be obvious on ultrasound findings or blood work, but in most of our patients, because their egg reserve is low, at least the patients that we treat at LAIVF, we don't want to lose precious amount of time. And if you can get 3 to 4 eggs, you want to get 3 to 4 eggs this month, get another 3 to 4 next month, get another 3 to 4 the following month. Then you got 12 eggs as opposed to just 4. So I think the distinction really has to be made, and it's critical. But that doesn't mean that everybody needs conventional IVF. I don't think we're saying that. What we're saying here is that we don't want to relate a message that minimal stim is better than conventional in a patient who has that full capacity of developing multiple eggs. Minimal stim has never been shown to be better, but it has been shown to be the same if you have a limited number of eggs. So if you have a limited number of eggs, then yes, you absolutely can do minimal stim. And I think what we should also talk about in the next few minutes is what are the different types or protocols that we can use to do a minimal stim. But I'll let you to your question, and maybe that's what you're going to ask next.
Well, I was actually going to ask, just to clarify, because you said that it wasn't any better. So I just want to reiterate. So if we do less stimulation of the medication in a mini IVF, that's not necessarily going to give different quality level eggs.
That's a good question. Yeah, it doesn't, right? Okay. And there is, I think we may have talked about this in one of the previous podcasts. So there are studies that looked at egg donors, minimally stimulated, maximum stimulated, over hyperstimulated. And then those eggs, when they're hyper overstimulated or minimal stimulated, were then fertilized and transferred into intended parents for the purpose of establishing a pregnancy, obviously. And the pregnancy rates were exactly the same. So whether somebody is over, hyper, normally, minimally, mildly, micro stimulated, does not impact the health of that egg. So we already know that. That's already been established.
Okay. Good to know.
Right. So I think the important thing is, what are the different types of minimal stim? Yes, and so one can use pills called Clomid, Femara, even tamoxifen has been used in the past. The latter two are kind of known as cancer drugs. So, but they can be used. They're fairly safe. And then Clomid has been around for a long time. There's a long track record. So when you take these pills, they're obviously not as strong because they use our internal hormones to grow the egg. So oftentimes you get maximum of maybe 3. 1 to 2 is very common. And sometimes just 1, even if we give these medications. So I would say typically 1 to 2, 1 to 3 is what you accomplish, 1 to 3 eggs, mature eggs, when you use the pill form. If you use injectables, you can get more, certainly, and that depends on the dose. But typically there are 3 different kind of protocols for minimal stim IVF. When somebody uses pills, that's a little cheaper, and certainly you're just taking pills. You're not putting a needle into your body for about 7 to 10 days. So some people prefer that option. The yield is lower. That's a downside. And then with the shots are more expensive. You're putting a needle into your body, certainly. With that, it can maybe cause a little more stress because of the injection versus, taking a pill. Although the pills actually can have more side effects, like mood swings, headaches, sometimes breast tenderness, hot flashes at times. So the pills, especially Clomid, actually can have more side effects, which is kind of interesting. So
for a typical patient, what would you suggest to a person who was going in to speak with a fertility specialist? I mean, what kind of questions do you suggest that she ask in terms of getting kind of what the best protocol would be for her?
Yeah, I mean, that has to be discussed with a fertility specialist. Once the workup is completed, the doctor will get a good full picture of what the underlying cause is, number one. And then based on that, a protocol can then be designed, whether that's going to be natural cycle IVF, minimal stim IVF, or conventional IVF. And these are all good options, by the way.
Right.
There's not like there's like a right or wrong answer in that sense, but more of a preference and kind of utilization of the best resources and time, risk assessment, and probably most importantly, the yield. What is the yield if we do one of these 3 options? And is that going to serve the patient's needs? That's probably the most important question that has to be answered, which then will allow us to plan that protocol or the next steps. And the fertility specialist will then review and discuss what the best option is. And then roadmap is then created, meds are ordered, and then becomes, showtime.
Great. It's really helpful to understand all of these different terms that get thrown out there in Google and other places like that, and also to know how it relates to us and our specific case. So thank you so much for talking about it. And also I want to encourage listeners to also listen to our other podcast about natural IVF, which is also helpful to know. So thank you, Dr. Bayrak.
Thank you so much.
Thank you for our listeners as well for joining us. You can find out more about Dr. Bayrak and LAIVF by visiting our website at www.laivfclinic.com, or follow us on Instagram and Facebook at LAIVF Clinic. And thank you for listening. Understanding Your Fertility is created by LAIVF. Please note that this podcast is intended for a broad understanding of the topics presented. It does not substitute for the medical advice or care of a physician-patient relationship. Podcast listeners should always consult with their healthcare provider regarding any medical condition that requires professional attention. Follow us on Facebook, Instagram, and Twitter. If the information on this podcast was useful for you, feel free to share it.